Thank you very much. It's always a pleasure, really a pleasure to be here. I mean, Basel is a fantastic city. It's also the crater of the establishment of the State of Israel. It's just around the corner here. Just that.
Next time you get a room there.
I know. I wanted to comment. It was too expensive to book me a room there. Thank you, Yuda, Rafael, Luigi. I saw Luigi here somewhere. I feel at home here. We're like family. And 29 years ago, Fred Epstein, my legendary mentor, used to have those small meetings. The small meetings are the best. I get lost in the big meetings. You cannot focus. So when you have a focused meeting like this, there is an inevitable repetition and overlap, but altogether, it allows you to bring your knowledge a step further. So this was a symposium in 1993. Were you there, Professor Müller? Yes, you were not. Michael Edwards was there, and unfortunately, he couldn't make it. So this is a Fred kind of titled Craniopharyngeoma, the answer. Of course, at the end of the meeting, there were more questions than answers. And I was wondering whether during those 29 years, how much change has happened. And I think there is a change. By the way, the book of the meeting was published by Karger, who sit just across the corner. This is the Tel Aviv Medical Center. This is where we work. We are an international department. Right now, we have Ukrainian fellows with us. This is a big story. And here's little Yuda. You see, he's hiding with a mask. And so it was really fun to have Yuda. And thank you, Luigi and Rafael, for allowing Yuda to go back and forth. This is very fertilizing. Just an opportunity to invite you in September to the AACNS, the meeting in Jerusalem. Also an opportunity to invite those of you who are pediatric neurosurgeons or have an affinity to pediatric neurosurgery to come to ISBN in Singapore. This is a concept I sort of borrowed from our friend Rick Boop in St. Jude. Tumors I like and tumors I hate, okay? And so like is above, hate is below, so we love to do JPAH, germ cell tumors are fine. Even medulloblastomas, peanuts are fine, ependymomas are fine, and then craniopharyngiomas. Craniopharyngiomas are just above the very malignant tumors. And I must tell you, I must confess that when I have a new craniopharyngioma, that this happens six to 9 times a year, I really get depressed. I get depressed because of many reasons. One of the reasons is that there are many choices. You have to choose between different treatment options. You have to sit with the parents. And what we're doing now, we are shifting the decision to the parents. We say, you can do this, you can do that, you can do that, you can do that. This is an endless discussion, especially with the intelligent parents who seek other opinions and this is, we've switched to what is called shared decision-making model. This is a different talk by itself. The whole topic of informed consent in general, any pediatric neurosurgery, I'm very interested in this subject. So it started with Harvey Cushing. Everything started with Harvey Cushing. It comes from the craniopharyngeal duct, where enough embryology and anatomy talks here. And Harvey Cushing said in a classical way, one of the most baffling problems for the neurosurgeon. So we discussed, Professor Müller also stressed, it's a slow-growing tumor. It has a bimodal age distribution. And actually, Yuda has asked me to cover also the difference between children and adults, and I reserved 5-6 minutes at the end of my talk, which is the story. This is the story of craniopharyngioma that I want to tell you. So I will cover this informative part of difference between children and adults. This is very important because the adult tumors are different, and because many children are operated by adults. And this was the question that was asked. some of the philosophy of the treatment for adults is replicated in children without understanding that it's a different disease with different implications. So these are the signs. The bitemporal hemianopsia is classical for tumors that press from below, but interestingly, many times the tumor presses the chiasm against the anterior communicating artery. So you will get exactly a reverse field, visual field defect. And of course, the endocrinopathies, which are stated on the graph. And Shelley gave her brilliant talk. We always insist on making a CT to see the calcification, at least for a baseline for the future. The beauty of the Puget classification, unfortunately she couldn't come, is that it is simple. Everybody can get it. 0, no hypothalamic involvement. 1 is hypothalamus displaced. 2 is clear hypothalamic invasion. French, simple. 3 grades. And if you look above, you see a tumor which is in the cell, basically, going into the sphenoid. As it says, in the middle is a tumor pushing upon the floor of the third ventricle. So this would be a displacement. And at the bottom is a classical hypothalamic involvement, anterior and posterior hypothalamus are involved. So what are the measures of success? Before the 1970s, morbidity and mortality. The patient is alive, fantastic. If he can move his hands and legs, even better. Then we had the Glasgow Outcome Scale. Then we had the Karnofsky, which is implemented mainly in the glioma area. And in the new millennium, it's different. We want a detailed neurocognitive measure. We want a formal neuroendocrine evaluation. We want a more formal neuroophthalmological evaluation. And we also want to see the long-term postoperative MRI, not only the CT scan. So it started with the cowboys. So this is Ghazi Asugil's paper on how wonderful he can remove craniopharyngiomas. He was an amazing surgeon. I spent time with him, really remarkable. And even him said, experience has shown that the larger the tumor, the greater will be the damage. So he already pointed out the classification of Puget. And then Harold Hoffman. I also am old enough to have spent some time in the operating room with him. I mean, when I think about it, it's terrible. You know, what Harold would do, he would go through the lamina terminalis and do blind movements in the third ventricle to peel off. It would peel eventually. And I think he ruined a lot of patients. It took time for the Toronto group and the surgical community to acknowledge that a lot of patients were ruined in Toronto. Of course, he was a master surgeon, a very amusing guy. But a lot of patients were ruined by those blind movements within the third ventricle. And I think what happens is that many people who do 1 or 2 cases every 5 years, they read those papers and they say, okay, I can do it. I can do it, and I should do it. And they go for radical resection. You can already smell my opinion about this. So then even Jeffrey Wissoff, my mentor, who is a very aggressive surgeon, and this is from 2009, already acknowledged that a quarter of the patients will recur. This is an underestimation. I think if you wait long enough, at least 50% of the patients will come back after GTR of craniopharyngiomas, not followed by radiotherapy. And this is from CHOP, that one of the first papers in 2004 that stated no difference between GTR and STR combined with postoperative radiation. So it's either GTR or the STR in a package deal together with radiotherapy. I think there was one study in Germany at one time, Professor Müller, maybe you can comment later, that tried to stratify STR without and with immediate radiotherapy. I think that was stopped. If you do partial resection, irradiate. If you wait, the residual will grow. And then, more papers came in from different groups. This is the group in St. Jude. I think this group, together with Professor Muller, is probably the only groups that really contribute to our understanding of craniopharyngiomas. I don't know how many of you know, but in St. Jude, everything grows by protocols. If you're accepted, and I send patients there occasionally, to be on a protocol, everything is covered. This is magical. The patient is covered, the surgery is covered, and every 6 months, a follow-up in St. Jude, including the flight and the family, is covered by the St. Jude Foundation. This is really magical. So they already started, this is from 2010, to realize that the endocrinological sequela is significant. So you can look at it. I mean, Rafael asked, what is the significance of being obese? It's not a little fat. They are very, very obese. So this is a common story after craniopharyngioma. The BMI increases. The child was excellent student, and then he struggles to make C's at school. He has personality changes. He has emotional outbursts and also some memory problems, because the mammillary bodies, it's not only about your appetite, it's also about your cognitive performance. And then this is from 2018. The papers, the exact numbers are not important, but the fact that our community started to look at quality of life as a term, as something you can measure, and you can stratify the patients by the way they were treated and what happens with them over time. And this is the fantastic data that from Rutkowski and some other people, including Pasa. And if you can look at the upper graph, this is the tumor control. You see that the GTR and the STR plus radiotherapy, they recur. And the GTRs also recur. And below, you see the survival. The survival is relatively good, but the tumors recur. And with the recurring tumor, the secondary step of treatment becomes more and more difficult and associated with more and more morbidity over time. And this is, of course, from Herman's group, and radical neurosurgical strategies leading to posterior hypothalamic lesions are not recommended. We've heard about it together with people from Vienna and other people. When you see craniopharyngioma with a K, you know it's from Germany, right? This is how you can trace the origin of the tumor. And then more papers, again, from Müller and other people. Hypothalamic sparing treatment approaches are recommended to minimize quality of life and children damage over time. Tom Merchant, again, in 2010, started with radiotherapy. So on one side, we started to acknowledge that radical surgery is harmful. On the other side, the radiotherapy has improved. On a different scale, the experience has been going down because of dilution between so many centers. That, by the way, occurs also in the United States. And this is, the first statement from a surgical center, okay, from Tom Merchant. Conservative surgery and radiotherapy results in a long-term disease control in pediatric craniopharyngioma, comparable to the results obtained with radical surgery alone. Then we started with the area of intracystic therapy. It started with phosphorus, then with bleomycin, then there was a thing with bleomycin that it makes the capsule more strong, therefore it will make further surgery easier. Never been really proven. And then the papers on interferon. I was part of the study on the lower left there, and this is, I summarized for you, the intracystic therapy is a temporary measure. It is not curable, including the interferon. And then the protons appear, protons versus photons. The protons are sinners. The proton centers are sinners because until recently, we did not have any clinical results. We always see dosimetries, and the dosimetries seem better with the protons compared to some of the old photonic radiotherapy. We have a talk about that, so I will not dwell too much. But this is from Rick Boop in Cambridge 2018, academic achievements, and you see the reading score and the mass score with protons seem to be better. I'm not sure I buy that 100%, but at least with this data in mind, I think there is no choice. But if you can, especially in little children with craniopharyngioma, we tend to send them. In Israel, it's sending them abroad. We usually send to Vienna in the last few years, but before that, we did send to the United States. The prices of protons also have gone steeply down, which also helps with shifting those patients to live 2 months abroad. I think it is worthwhile. If I was a parent, I would go for it, although as an academician, I'm not 100% sure that in terms of damage, this is, by the way, true not only for craniopharyngiomas, it is true also for medulloblastomas, for ependymomas, posterior fossa tumors. I'm not so convinced, but I think as a parent and as a referring physician, I send them for protons. This is the summary of the proton versus photon dilemma. I think at this point, they've just got to go to protons, and then the targeted therapy. I think that talks about it, so I don't need to dwell on that. So I want to tell you a story that we coined it the tale of two craniopharyngiomas, the Tale of Two Cities by Charles Dickens, and this was two craniopharyngiomas that were operated at the same week in my department, and I want to tell you about them. The first one we call Craniopharyngeoma 1. It's an 8-year-old boy with stunt growth, vision normal, endocrine quite normal. Craniopharyngeoma 2 was 12 years old with weight gain, so he had the weight gain before the surgery, but also headache and vomiting and vision, right temporal field loss, normal levels of no endocrinopathy. This would be craniopharyngioma 1. This would be a Puget grade 1 to 2. You see it's maybe epicentered in the cella. You see the fleck of calcium on the CT scan. And this is craniopharyngioma 2. There is a solid part sitting below, and there's a cystic part pushing the hypothalamus from down above. Concentrate on the left side. Craniopharyngioma 1 on the 3rd of June had an endoscopic transsphenoidal approach from below. Magnificent operation. You've got all the anatomy, so beautiful. And I convinced my colleague, Professor Sriram, who did it, I was next to him, to stop at the hypothalamic part going above. There were no intraoperative complications. Craniopharyngioma 2, we went with an endoscope from above. We fenestrated the cyst. We left an ommia. No intraoperative complications. So this is craniopharyngioma 1. Okay, after the approach from below, you see a very nice hole, but we knew that there is tumor above at the hypothalamus. You see it. You also see that fleck of calcium sitting up on the CT scan. This is craniopharyngioma 2, approached by endoscopy from above. You see the catheter sitting inside the cyst, and then the cast of tumor sitting below. So look at the left side. Craniopharyngioma 1 operated from below, had DI, hypothyroidism, hospital stay 2 weeks. He's still on hormone replacement, more than 2 years. Craniopharyngioma 2 from above, 5 days in the hospital, intact. Both were sent for protons. Okay, this is craniopharyngioma 1. You see a residual tumor stable for 3 years. Craniopharyngioma 2, also stable for 3 years. They were both operated in the same week. What will happen to them over 10 years? I don't know, but I'm very happy with craniopharyngioma 2 and intact, maybe one of this 1% that you've shown, just 0 complications. Now, what is an acceptable morbidity? Is there a term called acceptable morbidity? And what is a non-acceptable morbidity? So let's talk about the non-acceptable morbidity. Being blind is non-acceptable. How about being blind in one eye? It depends on what stage you go into the surgery. Neurological deficit, don't forget, it's not only the hypothalamic obesity. You can get hemiplegic. I have a whole cohort of children that were operated by my predecessors before I came, severely damaged. And DI without preserved thirst mechanism is considered non-acceptable because this is very difficult to control, even in the most advanced places. How about DI with preserved thirst mechanism? More acceptable, but don't forget, how do you treat DI in Africa or in a third world country where you have no support and no way to be examined or to do tests? What do you do in this place? I just remind you that in 2040, 85% of the children in the world are going to be born in Asia and Africa. Now, personality changes, emotional outbreaks, memory problems. I would shift them from the left to the right because you get a different boy or a different girl. Of course, it's not 0 to 100. It depends on the degree. I want to show you two patients. The first patient, from 2006, she presented at 12 with 2 weeks of headaches, bilateral papilledema. She was preserved endocrinologically, and she had this massive cystic craniopharyngioma. You see the flecks of calcium, but the cyst goes all over the place. It goes to procella, it goes to the posterior fossa, and this is the MRI. I'm sorry about the quality. This is just pre-PACs in my hospital. We injected some contrast to see that all the cyst cavities are connected. So we put an Ommaya inside by endoscopy. You see the Ommaya is too long, so it rolls into the cyst. But it worked. We took also some pathology. It was a craniopharyngeoma. The Ommaya was tapped 5 times. After the cyst went down, the Ommaya also drained a little bit the ventricles and stopped being too effective. And I decided to take her for surgery. Why did I decide to take her for surgery? With the logic that I will reduce the residual cyst so as to reduce the radiation field. I knew she would get to radiotherapy. So in September 2006, I took her for pterional craniotomies with the aim that I told you. The cyst wall was very attached to the brainstem. I was peeling it off the third nerve, the oculomotor. And at one point, I decided that, I'm causing more damage than benefit. This is an MRI a month after the operation. Of course, she came out with a full third palsy, which is until today. After that, she was hospitalized for a few weeks with significant electrolyte imbalance going between the eyes, salt wasting, sodium up, down, but recovered. The CT showed a smaller cyst, and then she got radiotherapy. At that time, she got it with IMRT, you see her, the dosage, 54. She had a long rehabilitation, but she recovered. So what does she have today? She has GH and T3-4 deficiency. She has a third nerve palsy. All these operations to try to open her eyelid are not very helpful because after you open her eyelid, the eye is deviated and she got diplopia, she has headaches. So this is a mess, but she got used to it. So this is her. She's stable now for 12 years. So today I would avoid the open surgery for sure. I would just put a drain and send her for protons. A third nerve palsy is a significant morbidity. I do not consider her a success. Some people would say she's alive, but tumor is stable. Maybe she's a success. Now, this is a 3.4 years. Actually, Shelley presented this boy. So you've seen those scans. So I agonized on the decision-making in this. This is a nightmare because this is a big, solid craniopharyngioma. There's no place for drainage here. I knew it was a craniopharyngioma. Shelley said so. And although Shelley never commits, she said so. And then I really agonized on the decision whether to send this boy to upfront radiotherapy. This is quite big. It's quite big of a lesion, and I did what I do many times. I consulted with Rick Boop and Tom Merchant, and they said if you can get the tumor smaller, the radiation field will be smaller, and you've seen this this approach. This is an interhemispheric approach. It's a long approach, but it went well. And we left tumor. You see within the yellow circle, you see the tumor which is left anteriorly. I think I was very happy with the amount of tumor, knowing that this boy will go. This was Corona time, and as Shelley told you, within 3-4 months, while waiting to be shipped, Vienna was closed. At that time, the tumor grew. Shelley showed you this. So what to do? The tumor grew. So we're back. So I said, the corridor is already there. Interhemispheric, you're inside. Let me remove it again. So this is what we did. Maybe we removed a little bit more than before. You see the pictures after the second operation. Went to Vienna in August 2 years ago. He had a few shunt-related surgeries, as Shelley told you. Had moya, built the vessels through the craniotomies, and this is the boy. This is how he developed. This is how he is. You cannot catch him without something to eat in his hand. He was the cutest boy, and this is what he has. Not to mention that he has panhypopituitarism, some visual impairments, and some cognitive impairments. So this is the case. 5 minutes for adults versus pediatrics. Okay. This is a special book on that topic. You see the first paper is from a French group. The second paper is from our hosts, Raphael and Yuda, wrote about adult craniopharyngioma. So craniopharyngioma has a bimodal age distribution. It is two distinct biological entities, different in almost every aspect. You see, this is due to different histological tumor types, different location, different neuroendodevelopmental stage. So, it works. So, about histology, as you know, the pediatric craniopharyngioma is mostly adamantinomatous. In the adult, it's mostly papillary. The adamantinomatous tends to adhere to the surrounding because of interdigitation. In children, it's mostly cystic and solid. In adults, it can be both, but more solid. The origin of the tumor in children is mostly infradiaphragmatic. In adults, it's supradiaphragmatic. Hydrocephalus is very common in children and less common in adults. And then the endocrinopathy, as you see in the pediatric, they present many times with DI, delayed puberty. In adults, the clinical presentation is more subtle. In children, also the post-operative endocrinopathies are more significant. And of course, the consequences for growth, development, and fertility are bigger. The other thing is the visual complaints. You see in children, 30% present with visual, and in children, higher percentage with papilledema. And it relates a little bit to the fact that children many times have what we call a belle indifference, that they do not complain about things they suffer. And then neurobehavioral, emotional liability, recurrence rates we discussed in children are higher probably than in adults. Mortality in children increases, and the 5-year survival rates are similar between children and adults. So, in conclusion, the adult-onset craniopharyngioma contains a more favorable characteristics. Adults by nature already completed their neurodevelopmental outcome. Outcomes are better in adults than in children. I want to show this case. This is a 42-year-old woman, failed pregnancy, due to high prolactin. And from ophthalmology, she had left incomplete hemianopsia. She had high prolactin, not very high due to stalk effect. And this is what she had, a solid tumor within the third ventricle, in the suprasellar area. There was a right frontal interhemispheric approach, classical adamantimartus, craniopharyngioma. After surgery, she had left hemiparesis resolved within about 2 weeks. She had DI with minorin replacement, short rehabilitation process, and this is her residual. This is a subtotal or near gross total resection. I was happy with this, not to get too bold as you go down to the mammillary bodies and to the floor of the hydrocephalus of the hypothalamus. She got radiotherapy, and she's stable. She's doing great. This is what she had. She has central DI, central hypogonadism, but she carries out an independent life, and she has now a normal visual field. Now here's a teaser. Could we have taken this woman or the first case and just irradiated up front on a 3-4 centimeter craniopharyngioma? I don't know. I'm afraid that the information regarding this question will take another 20, 30 years to realize. But lately we had a small craniopharyngioma, and I was asking my friends in St. Jude, I knew it was a craniopharyngioma. Everything was a 1.5 centimeter lesion. So why don't we just zap? Yes, no. At the end, Stein, I don't know if you remember this patient from a month ago. At the end, we said, okay, let me ask Viram to take a biopsy from below, because it went all the way to the cellar. He did. I was standing behind his back, and he said, I want to continue. It's beautiful. It's separated. I can separate it from the chiasm. And look how beautiful it is. He said, sweet, please, do me a favor. Just take a bite and go away. This is what he did, and this kid is getting proton beam as we speak. So all this decision making, this is a photo, a painting I picked up at the Prado. Jesus among the doctors. Would be nice to have somebody helping you in this agonizing decision making. Come to visit Jerusalem in September. Nothing can be done without a team. Thank you very much.
Thank you, Shlomi, once again for an excellent presentation, excellent overview. Are there any questions from the audience?
Thank you very much for this excellent overview. My question is simple. After your huge experience, should we operate craniopharyngioma?
But I think the cystic ones are easier. You drain the cyst either by a stereotacticomia or by endoscopy, depending on yes, no, hydrocephalus to start with. And I would go there. So I think we shifted from radical surgery to subtotal combined with radiation, and then we've shifted to minimal surgery combined with radiotherapy. I don't think they should be operated on, even if there is a residual lump of 2 centimeters, even if they are in the cell. Okay, that's my view. Not everybody would accept that. Time will tell. St. Jude is coming up with another paper showing that approach of minimal surgery plus radiotherapy, 10-year progression-free survival. I have over 20 patients which I adopted this view. One has a recurrence now 15 years after the first operation. Shezafiel, I don't know if you've seen her scans, Shelley. So she has a cyst developing over the last 2 years in a place I cannot operate. So we're going to put an Omaya next week and then send her for re-radiation, which is a concept also With protons, there is a paper coming from Vienna now on radiation. If you space the radiotherapy by 15 years, what will happen with her in 20 years? I don't know. Remember, 20% of your craniopharyngiomas will do very bad. Whatever you do will do very bad. So you don't provide guarantee to the patients, but the concept of first do no harm on a chronic disease is a very important concept, especially that the radiotherapy has improved so much over the last 2 decades. Oliver.
Go ahead.
I just want to add that I think thinking about irradiation alone without surgery also implicates that we have made progress in terms of targeted therapy based on the fact that you have the tissue to analyze these tumors. And when you don't have the tissue, you have no choice, and there is no way to do innovative pharmacological targeted therapy because you don't know about the molecular structures. And I think later on there will be a talk focusing on this.
I can live without the academic interest of having the histological type in children. I can live with it personally.
Yeah.
Some cannot, but I have a slide in another talk of now. I have now 7 tumors that we treat in children without histological verification. The IPG, bilateral thalamic tumors, tuberculosis-associated tumors, NF-associated. Actually, Yuda wrote the paper on this. Tectal tumors, we make the diagnosis based on imaging, and we defer histological verification. It took time for the oncologist to live with it. Says, well, I'm going to treat oncological treatment without seeing those slides, and in children, since in most cases the BRAF pathway, in all cases, I've never seen in a child BRAF treatment being so successful. I can live without the histology, provided that there is no differential diagnosis. That people say no, but it could be. Shelley showed one case that eventually it was a germ cell tumor, right? So.
What about BRAF mutation?
So this is relevant for adults. It's relevant for adults. So in an adult case, many people would like to have histology and molecular biology to have that tool available in case the molecular biology shows the Kaya and the BRAF are in the right direction. In children, it's just not there.
Why not?
Why not? Because it's a different tumor. Yeah, I don't know.
Thank you, Shlomi. Is it working? Yeah, it's always a pleasure to listen. And is it working?
Yeah, we hear you.
You hear me? Okay. Sorry. It's always a pleasure to listen and to gain from your experience. So now the final question to you and to Professor Müller is, if you had the resources and you have 20 centers who will follow you and you can design a study, what would be your question, or how would you design it, surgical-wise, and also to Mr. Müller?
It's very difficult to stratify surgical patients in general. I've done it once in my life in the IIHS study. It's very, very difficult to do surgical stratification. So what is common practice in oncology? Treatment A, treatment B. If you don't give your permission to be randomized, you don't get treatment B. That's common practice in oncology. Just doesn't happen in surgery because it is so damn difficult to sit with patients and tell them, I can operate your child aggressively, I can operate your child modestly, the literature has given it. Please sign to be randomized. Almost impossible to do it. So I think to do studies which are prospective in terms of the aggressiveness of surgery is probably not going to happen. So we have the retrospective analysis. What Professor Müller and his team did is remarkable in terms of data that we can extract, but even that is incomplete with some questions that are difficult to answer. I really don't have a good answer to you. Maybe Professor Muller.
Actually, in our trial, we tried to randomize the time point of irradiation after incomplete resection, and and we wanted to know as a primary endpoint the quality of life, and we didn't achieve enough compliance for this randomization. We saw that irradiation was effective when it was done right away or later on in terms of relapses.
Yeah.
Asking for a way to proceed, I think teams should be conscious of potential side and long-term effects. Whatever you do, you should try to spare the hypothalamus. But when it's a chronic disease and you see that the initial hypothalamic involvement has major independent impact on the outcome of the patient, the next question is indeed, do we have novel, for BRAF mutated patients, we say, that's perfect. But these are the adults. My question is, what are the pathways in children? And this we have to analyze, because when we have potential medication which could contrast the aggressiveness of the invasion of the hypothalamus, could influence the growth of these sometimes very aggressive biological growth behaviors on these tumors, that might be a perspective.
That would be a dream.
Yeah.
Of course, I just tell you a little anecdote. In my friend Sergei Gorelishev in Moscow, had a big cystic craniopharyngioma. He wanted to put an Omaya and train it because he's going to pediatric meetings. So he understands. So he went to Konovalov, the big chief at Rodenko, and he said, that's what I want to do. So Konovalov told him, Professor Gorelishev, do you want to ruin microneurosurgery? It is so beautiful, you have a cyst, you separate it from the vessels, it's nice. So anybody who enjoys subarachnoid work, but not good.
Okay,